Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I want to discuss with you the guidelines in ovarian cancer management. So, what are the objectives today? Discussing the guidelines in ovarian cancer according to the Spanish Society of Medical Oncology 2020, as regards the diagnosis, the pathology and biomarkers, and treatment and the follow-up. Okay? Okay. Let us start with diagnosis of ovarian cancer. Early stage ovarian cancer is frequently associated with non-specific symptoms. Okay? But in late stages, ascites, abdominal disorders, and pleural effusion are common. Okay? So, early there are many non-specific symptoms, but in late stages, you can find ascites, pleural effusion, abdominal disorder, persistent abdominal bloating, and so on. Okay? In women with symptoms suggestive of ovarian cancer, physical examination, lab test with cancer antigen 125, and pelvic ultrasonography are recommended at a first level. So, you should start your diagnosis by evaluation of the symptoms, by doing physical examination, by doing pelvic ultrasound, which is very important, and ask for tumor marker CA125. This is the basic for diagnosis. Okay? Okay. Also, there is an important high level of human epididymis protein 4 has an important role to identify malignancy with a similar sensitivity to CA125. But the advantage of HE4, it has a higher specificity. So both CA125 and the HE4 are included in the risk ovarian malignancy algorithm. It's called RUMA. Okay? By the way, this RUMA, risk ovarian malignancy algorithm, is different in premenopause than in postmenopause. If we found the score in premenopause 1.4 or higher, is considered high risk, while in postmenopause 2.99 or higher is a high risk. Okay, this is as regard to the score of RUMA. And if you wanna more details, I have a previous lecture about ovarian tumor. You can go to my web channel, my YouTube channel, and find the lecture of ovarian tumor in details. Okay? Okay. So you can depend on human epididymis protein 4 and CA125. And as I said, human epididymis protein 4 has a higher specificity than CA125. So if we use the both of them, we have a better diagnosis. Okay? As what we are using in ROMA, or risk of ovarian malignancy index, or algorithm, risk of ovarian malignancy algorithm. Okay, in patient with presumed ovarian cancer, computed tomography, imaging of the thorax, abdomen, and the pelvis will define the extent of the disease and provide information to plan treatment options. So, for all gynecologists, you should start your diagnosis with taking history, Knowing the symptoms, the patient complain of persistent abdominal bloating, abdominal distension, abdominal pain. Okay. Also, there may be ascites, there may be pleural effusion in advanced cases. Okay. So this is as regard the symptoms. With physical examination, you can detect many signs like pelvic abdominal mass or abdominal mass. There is ascites. The mass may be bilateral or unilateral. Okay, so you can diagnose the pelvic lesion or pelvic abdominal lesion. Okay, okay, by pelvic examination. Also, second step is to do transvaginal ultrasound and abdominal ultrasound to diagnose the ovarian mass, if it's cystic or solid, and the criteria of malignancy in the mass. Then what is next after ultrasound is to ask for lab investigation, tumor marker, like CA125, because it is the most important in epithelial ovarian cancer. Also, you should search for human epididymis protein 4. As I said, you can use ROMA algorithm, risk. This score can give you data about suspicious of malignancy. And human epididymis protein 4 carry higher specificity than CA125, as I said before. So using both of them is important, as in Roma algorithm. Okay? Okay. What else next step? Now you are diagnosing ovarian cancer. You need to do more imaging. What you are going to choose, CT, computed tomography, or MRI? I'm going to choose CT. The guideline said CT is important. CT on the pelvis, abdomen, and the thorax. So after you diagnose with ultrasound and the tumor marker, go on to CT. CT on the pelvis, abdomen, and thorax. Okay? Why? Because you want to know the extent of the disease and provide information to plan treatment options. Okay? I hope it was clear enough. What about MRI and PET scan? Magnetic resonance imaging and the positron emission tomography, CT, are not included in the routine preoperative stage. Okay, so it is not a routine work to do MRI or PET scan. Okay, but could improve the accuracy of the evaluation of the advanced disease. So sometimes I need an imaging to help me more in advanced cases. So I may need MRI or PET scan. Okay? But as a routine preoperative staging, no. It's quite enough to do CT, chest, abdomen, and the pelvis. I hope it is clear enough. Okay. What about laparoscopy? Laparoscopic surgery is the mainstay not only in staging of ovarian cancer, but also in the pathologic diagnosis. What about the pathology and the biomarkers? According to the WHO classification, there are 5 major subtypes. And if you wanted to know about them, you can find my lecture on the YouTube channel about ovarian tumor in details. Okay. What are the 5 types according to WHO classification of epithelial ovarian tumor? High-grade serous carcinoma, low-grade serous carcinoma, clear cell carcinoma, endometrioid carcinoma, and mucinous carcinoma. Okay, what about the use of immunohistochemical panel? The use of an immunohistochemical panel including Wilms tumor 1, p53, progesterone receptor, and napsin A has been suggested to assist in the diagnosis of cases in which the histologic type is difficult to establish. So there is some cases, there is controversy about the histological type of this tumor. So immunohistochemical panel help you, okay? Okay, what about BRCA gene mutation? Is it needed to be done? Yeah. In non-mucinous tumor, study of germinal and somatic if possible. BRCA mutation must be completed after pathologic diagnosis. Why? It's important due to its implications on hereditary counseling. You should counsel this family about the risk for other members of the family. Also for prognostic information and the therapeutic strategy, because I may need certain special therapy in patient carrying BRCA gene mutation, as we'll see later on. So it is important. Okay, for therapeutic decision, it would be desirable to have also information on tumor homologous recombination, HR status. Okay, let us go to the treatment of ovarian cancer, which depends on is it early stage, stage 1 or 2, or advanced ovarian cancer, which include stages 3 and 4. Okay, so when we are talking about early stage, I mean 1 and 2. Late stage or advanced stage, I mean 3 or 4. Okay, let us start with early stages. What is the role of surgery? Okay, treatment for early stage consists of staging surgery or what's called staging laparotomy. You first start with peritoneal wash or taking sample of the acidic fluid, or do peritoneal wash with saline and send the sample for the lab. And the careful inspection and the palpation of all peritoneal surfaces, the serosa of the entire digestive tract and the bowel mesentery. Then go on to do hysterectomy with bilateral salpingo-oophorectomy, bilateral pelvic and para-aortic lymphadenectomy, omentectomy, and random peritoneal biopsies. Okay, this is the surgery for early stages. Lymph node dissection can safely be omitted in grade 1 mucinous tumor. Okay, both open and the laparoscopic approaches are acceptable as long as an experienced gynecologic oncologist perform all the procedure. So there is importance to do the operation with experienced gynecologic oncologist. Okay, if patient was referred after incomplete surgery, she did surgery for ovarian tumor, for epithelial ovarian cancer, and it was incomplete surgery. Okay, what you are going to do? Staging procedure should be offered. So reopen this patient and do staging laparotomy and complete, as I mentioned before. Okay. What about fertility sparing surgery in early stages of ovarian cancer? Fertility sparing surgery based on unilateral salpingo-oophorectomy and the complete surgical staging can be safely offered to which stages? Stage 1A and 1C1 low-grade ovarian carcinoma. So, which stages I can do fertility sparing surgery for them? patient carrying stage 1A and 1C1 low-grade ovarian carcinoma. Let us continue with the early stage ovarian cancer. We started with surgery, as I mentioned before, then the rule of adjuvant treatment. Adjuvant treatment means the post-operative chemotherapy. So adjuvant platinum-based chemotherapy after staging surgery is indicated in high-risk early stages 1A or B, high-grade, or 1C, 2A. Okay? The recommended regimen is paclitaxel, carboplatin, but single agent carboplatin is also considered a reasonable option. How many cycle regimen? 6 cycle regimen is recommended in high-grade serous carcinoma, but the optimal duration remains controversial in the rest of histological subtypes. So in high-grade serous carcinoma, you should give 6 cycle regimen. What about the other subtypes, histologic subtypes? There may be 3 cycle. Yes, it can be accepted. But remember, in high-grade serous carcinoma, 6 cycle regimen is recommended. Sorry? Okay, let us go to the advanced stages. As I mentioned before, stage 3 and 4. Let us start with the cytoreductive surgery. Cytoreductive surgery plays a crucial role in the treatment of advanced ovarian cancer. The presence of visible residual disease after site reduction is a major prognostic factor with an important negative impact on survival. Thus, the goal must be to obtain a complete site reduction. So, you are going to do site reductive surgery or debulking surgery. You should remove all the tumor, all the nodules, metastases in the abdomen, pelvis, and everywhere. Don't leave behind you any tissue. Why? Because it is an important, this residual, if there is residual tumor, it has a worse prognosis. So you should remove every malignant tissue inside the pelvis and the abdomen. Okay? So we call it cytoreductive surgery. That's why we call it cytoreductive surgery. Okay? And my goal is to obtain complete site reduction. Okay, surgical effort must be maximal, and surgical treatment may include hysterectomy, double adenexectomy, omentectomy, extensive peritonectomy, bowel resection or excision of any enlarged nodes. However, if there is a question here, should I remove the lymph nodes in all cases in advanced stages? The answer is no. According to the Lion trial lymphadenectomy, in primary completely debulked advanced ovarian cancer with clinically negative lymph node, you shouldn't remove this clinically negative lymph node according to the results of Lion trial. Okay? So, you should look first if this lymph nodes clinically pathologic or appears normal. If normal, no lymphadenectomy in advanced ovarian malignancy. This is the result of Lion trial, and this is the guideline as I mentioned. Okay? So, we are going to do hysterectomy, double adenexectomy, omentectomy, extensive peritonectomy, bowel resection, or excision of any enlarged clinical evidence of enlarged nodes, you should remove it. But if it is not clinically suspected, normal, it appears normal, so you are not going to do lymphadenectomy. I hope it is clear enough. Okay. Several studies and meta-analysis suggest that the expertise of the surgeon is of utmost importance in the outcomes, and thus the recommendation is that patients should be operated in highly experienced centers. This is very important. Okay, both approaches, primary debulking surgery or neoadjuvant chemotherapy, followed by interval debulking surgery, can be considered valid, although primary debulking surgery remains as the preferred primary treatment when complete cytosol reduction is feasible and the patient is operable. Okay, here we are talking about the neoadjuvant chemotherapy. What is meant of neoadjuvant chemotherapy? Chemotherapy can be given before operation to reduce the amount of tumor mass, reduction of the tumor mass, and sometimes it makes the case more easily operable. Okay, so they start with chemotherapy, then do the staging, laparotomy, and so on. Okay, here the question: in comparison, if we started with primary debulking surgery, is it better, or giving chemotherapy first, then doing surgery? So we call it interval debulking surgery. So when I say interval debulking surgery, I mean I started chemotherapy first, then I do surgery. So we call it interval debulking surgery. Okay. So in comparison, any one of them has higher importance or better. Both of them can be considered valid. Okay. But primary debulking surgery remains the preferred primary treatment when complete cytoreduction is feasible and the patient is operated. So in many centers all over the world, they start with primary debulking surgery. They start with operative surgery, not chemotherapy. Start first with primary debulking surgery. Okay? The only need for neoadjuvant chemotherapy, to start with chemotherapy, then do interval debulking surgery, is when the case is inoperable. Okay? Or the operation will not be easy. Okay? But primary debulking surgery remain the preferred primary treatment when complete cytoreduction is feasible and the patient is operable. Standard post-operative treatment in advanced ovarian cancer consists of combination of carboplatin and paclitaxel every 3 weeks for 6 cycles. So carboplatin and paclitaxel is given every 3 weeks for 6 cycles, as I mentioned before. This is the post-operative chemotherapy. So we started with primary debulking surgery, then we give post-operative chemotherapy. Okay? What else in chemotherapy post-operative? Single agent carboplatin or weekly chemotherapy could have even worse outcomes in vulnerable elderly patients. So please don't start with single agent or weekly chemotherapy because it has a worse outcome. So the regimen should be 3 weekly 3-weekly regimen remains the standard for all ovarian cancer population. Okay, according to last European Society of Medical Oncology and the European Society of Gynecologic Oncology consensus, currently intraperitoneal chemotherapy is not standard of care. So, intraperitoneal chemotherapy is not standard of care. However, it could still be considered in certain selected patients. Who are the patients who may need intraperitoneal chemotherapy? Patient with stage 3, less than 1 centimeter residual disease after debulking surgery. So stage 3 associated with less than 1 centimeter residual disease after debulking surgery, you can use intraperitoneal chemotherapy. But take care. If the patient taking bevacizumab, if it is given to this patient, you shouldn't give intraperitoneal chemotherapy. So, in this patient, intraperitoneal chemotherapy and the patient didn't receive bevacizumab. Should be clear enough. But should intraperitoneal chemotherapy as a routine? No. As a standard? No. It's not a standard of care. And I said the exception in selected patient with a stage 3 and less than 1 centimeter residual disease after debulking surgery. Okay. Is there any rule for hyperthermic intraperitoneal chemotherapy? Hyperthermic intraperitoneal chemotherapy cannot be considered standard treatment and shouldn't be offered out of clinical trials. So, it is not a routine work or treatment in ovarian cancer. So, it is only used in clinical trial, in research, but don't use it as a standard treatment. It is not considered the standard treatment. I hope it is clear enough. Okay, let us go to one of the anti-angiogenic therapy, bevacizumab. Bevacizumab, 15 milligram for each kilogram or 7.5 milligram for each kilogram every 3 weeks for a maximum of 15 months is the dose of bevacizumab. In addition to carboplatin and paclitaxel, and it is specifically recommended in patients with stage 3 and residual disease or stage 4. So bevacizumab is indicated in patients with stage 3 and residual disease after debulking surgery or stage 4. It works like anti-angiogenic therapy. We know the vascular endothelial growth factor. It was found that the tumor cells has an expression of protein of vascular endothelial growth factor. This bevacizumab affecting this vascular endothelial growth factor, preventing the tumor growth and regeneration. Okay? So, preventing the growth of the tumor. So, this is as regard the bevacizumab. Okay, what about the maintenance treatment with PARP inhibitors? What is PARP? PARP is the abbreviation of poly-ADP ribose polymerase inhibitors. Okay, PARP inhibitors. It was found that olaparib, and niraparib are medications under the group of PARP inhibitors. Okay, so it was found that olaparib with or without bevacizumab or niraparib after partial or complete response to first-line platinum-based chemotherapy are highly effective. In which type of patient? Those with BRCA gene mutation. So it is strongly recommended. So PARP inhibitor is strongly recommended in patient carrying BRCA gene mutation. Please remember this very well. Either using olaparib with or without bevacizumab or niraparib after partial or complete response to first line platinum based chemotherapy. These drugs are highly effective in BRCA gene mutation. But remember, this patient should have partial or complete response to first line platinum based chemotherapy. Okay, it is highly recommended to use niraparib or olaparib combination with bevacizumab for patients with HRD, which is homologous recombination deficiency tumors. So, in patients with HRD tumor, it is highly recommended to use niraparib or olaparib plus bevacizumab. Okay? In the HRB subgroup, maintenance with niraparib can also be considered, although bevacizumab remains as a reasonable alternative. So, in a specific group of with HRB subgroup, niraparib can be considered for maintenance treatment, but at the same time, you can use an alternative for this, which is bevacizumab. What about surgery for relapsed ovarian cancer? Okay, surgery should be recommended for patients with platinum therapy-free interval more than 6 months and no residual disease after first surgery and good performance status, PS from 0 to 1. Performance status 0 means the patient is mobile, can do self-care, can go to work, and so on, so no limitation in his life. This is as regard the performance status 0. 1 still can give himself the care, can do care for herself, also can move, can do the work, but with some little restriction. So 0 and 1 is considered good performance. So what else indicated? Absence or less than 500 milliocytes. So patient came to you with relapse of ovarian cancer. What is the indication to do surgery? The patient should carry the following items. Should have the following, patients should have the following items. Platinum therapy free interval more than 6 months. No residual disease after first surgery. Good performance status. The general health in BS between 0 and 1. Good performance status. And the absence or less than 500 milliocytes. This item should be fulfilled before you recommend the surgery for such patient with relapsed ovarian cancer. Is there any rule for positron emission tomography, computed tomography, what's called PET-CT scan? Yes. Could improve the selection of candidate for secondary cytoreduction. Lastly, what about the follow-up of such patient with ovarian cancer? We can divide the patient into three main groups. Okay? In the first 2 years, as in this area, from 2 to 5 years after the end of treatment, and the third group from 5 to 10 years from the end of treatment. Okay? What you are going to do to the patient in each visit. Evaluation of the symptoms, if there is abdominal pain, bloating, abdominal enlargement, okay? And do physical examination if there is mass, pelvic mass or abdominal mass, or signs of cachexia, supraclavicular lymph nodes, lower limb edema, so on. So you should do physical examination, take history from the patient and know any symptoms, abnormal symptoms. Then ask for lab for tumor marker CA125 and the blood test. Then do CT scan every 3 to 6 months. So in the first group, in the first 2 years after end of treatment, you should see the patient every 3 months and evaluate the patient with regards to symptoms, physical examination, and do CA125 every 3 months. CT scan in some centers done in this group every 3 months, and then others recommend to do it every 6 months. Okay? So we should, in the first 2 years after the end of treatment, ask the patient to come for follow-up every 3 months. What about if the patient in the treatment between 2 years and 5 years? I should prolong the duration of follow-up? Yeah. Every 6 months. Ask the patient to come for follow-up every 6 months, so long as everything is fine, and do also history, do complete physical examination, and do CA125 serum level and the blood test, and CT scan every 6 months. What about if the patient in the group or that end the treatment 5 to 10 years? Okay, I should prolong the duration in the follow-up and frequency of visits yearly. Every year you should see the patient and evaluate the symptoms, do physical examination, ask for CA125 and the blood test, also CT scanning every year. This is for the patient 5 to 10 years after the end of treatment. Evaluated every year. Okay, so in the first 2 years, every 3 months, between 2 and 5 years, every 6 months, from 5 to 10 years, at the end of treatment, you can see the patient every year. And this is the end of this lecture. I hope it was clear enough. This is my box published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book, and the medical disorder and pregnancy book. This is my link on Amazon as an author, and this is my link YouTube channel, and this is my blog spot, and I'll put my site links on Amazon on first comment, and also my link on YouTube channel in another comment. Thank you, everybody. Wishing you all the best.